will actually shorten the second stage of labor. It will it's a maternal benefit um, in delivering the fetus. So it gives less it will give an effect that the mother will exert less thereby um thereby there is a less chance of aggravating the blood pressure.
All right. So it shortens the second stage of labor, thereby preventing any further increase of your BP due to one, the contractions of a baby about to deliver, and the increased BP status of your patient. Okay? Um,
Noted, Doc.
Okay. What is the maximum dose of your methyl dopa? So these are your hypertensive agents. What before you do a cesarean section, you have to have maximized all your hypertensive agents. So what are the medications that we could use for our hypertensive patients? In this case, it was not needed because went to increased BP already 35 weeks. When patient went to the ER already 3 cm and the labor progressed nicely. But what if this happened earlier and you are contemplating on prolonging and you're trying to prolong the pregnancy because trying to control the blood pressure? What are your hypertensive agents that you could use before you say, oh, this is uncontrolled hypertension, we have to do a cesarean section? What's the what what's the most common drug that we give to hypertensive patients? We start first with the oral regimen.
Doc, the basic one is methyl dopa,
Okay?
500 milligram. Then your
500 milligram ba ang
yes.
preparation ng methyl dopa? Okay. Its dosage is 250 milligram per tablet. Okay.
Okay.
How do
Okay
we
po, Doc.
give methyl dopa?
You can give it uh, the TID 3 times a day.
Okay, we give it 3 times a day. One
Yes.
tablet 3 times a day. What is your maximum dose?
3 grams.
Okay, 3 grams is your maximum dose. Meaning, if it's a 250 milligram tablet, you could give as high as how many tablets per day? How many tablets 3 times a day?
Six.
If it's 250 milligrams, you could give as much as 4 tablets 3 times a day for you to
Okay.
achieve that BP control. I've already asked this with the medrep. They couldn't give it at they couldn't make it at at a higher dosage, meaning, oh, why just not make a 500 milligram or a 1 gram tablet? Because it causes anxiety to the patient whenever I do that. Oh, you
Mm.
drink 4 tablets 3 times a day. Doctor, I will drink 12 tablets in a day.
Mhm.
And basically, the limitation would be cost. It would be expensive. Because one 250 milligram tablet would cost around 20 pesos. Okay,
Okay
so
po.
they would like to, well, that would be pharmaceutical reasons, of course. One, okay,
Yes po,
although
Doc.
the recommended in your Williams will be labetalol, which is not available here in the Philippines. If it's still not controlled with your methyl dopa, with your oral agent, what do we give?
Um, it's either than oral medications, doc.
Tapos na tayo sa oral, wala ka namang ng ibang ibibigay, di ba? So what is your next step? This is IV.
Hydralazine, doc.
Okay, we give hydralazine, and what's your formulation? And
For
we give it.
5 milligram IV
Okay.
PRN every
Up to
20,
how many doses?
maximum of 30 milligrams.
Maximum of 30 milligrams or 3 doses. It will depend upon what institution you studied. If it's still retractable, what else do we give? What's your last line? Well, not yet your last, but what's the um what else do we give before we say it's uncontrolled hypertension?
Magnesium sulfate, doc.
Is your magnesium sulfate for primarily for BP control? Your magnesium sulfate is for something else. It's either for prevention of eclampsia or neuroprotection for the baby. But for hypertension, magnesium would not be the therapeutic agent of choice.
Okay po, doc.
We reach for our last line of defense would be to use a nicardipine drip to control your blood pressure. So you see,
Cardipine
you have a lot of armamentarium to exhaust before you do a cesarean section. But make sure you have your antenatal fetal surveillance, your fetal monitoring, because at the earliest sign of distress or with your obstetric indications, you could also do a cesarean section, but not not cesarean due to uncontrolled hypertension. Okay?
Yes po, doc. Thank you, doc.
Yung preterm labor naman.
Wait lang.
Thank you, doc.
Simple lang, no?
Doc, naka-disable po yung
Ay,
screen.
sorry. Lumipat na kasi ako sa laptop. Okay, go ahead.
Can you see my slides na po?
Go ahead.
So, good morning po. For the last case presentation, I will be presenting po on GI bag. So, this is a case of AA, a 24-year-old G1P0 single admitted last April 14, 2021 with the chief complaint of vaginal spotting. She has no known comorbidities, no known allergies to food and medications, no previous surgeries. Family medical history are unremarkable. She is a non-smoker, non-alcoholic beverage drinker, denies illicit drug use, currently unemployed, and cohabiting for 1 year with a 27-year-old productions operator. She had her menarche at 12 years old with regular intervals, duration of 3 to 4 days, consuming 3 regular pads per day, moderately soaked with no associated dysmenorrhea. Patient had no history of oral contraceptive use, no pap smear was done. She had her first sexual contact at the age of 20 with 3 non-concurrent sexual partners, no noted dyspareunia or postcoital. She is a preemie-gravid with last menstrual period last September 25, 2020, 28 weeks and 5 days age of gestation with estimated date of confinement on July 2, 2021. For the history of present pregnancy, patient missed her menses for 6 weeks. Pregnancy test was done, revealing a positive result. No other associated symptoms were noted, such as vaginal spotting or bleeding, no hypogastric pain. Patient went for a consult at a nearby health center where a transvaginal ultrasound was done, revealing intrauterine pregnancy of 6 weeks and 4 days age of gestation, and patient was given folic acid and multivitamins tablet once a day. Patient was then advised to repeat transvaginal ultrasound after 2 weeks. So after 2 weeks, transvaginal ultrasound was done at the same health center, revealing 8 weeks and 3 age of gestation with crown rump length, and patient was advised to continue folic acid and multivitamins tablet and start calcium tablet once a day. At 10 weeks and 2 days age of gestation, patient first sought consult at the Geneva OPD due to vaginal discharge. Baseline laboratories were reviewed and advised for additional laboratories such as FPS, BRDL, and HIV tests, which all are within normal limits po. Patient was then diagnosed with bacterial vaginosis and was given metronidazole 500 milligrams per tab twice a day for 7 days. Patient completed the treatment. During the interim, patient had an unremarkable pregnancy, and at a regular prenatal checkup at 24 weeks age of gestation, patient 75 grams OGTT was done, which revealed an elevated first hour postprandial of 181.87 milligrams per deciliter. So the patient was advised for food diary, TN diet, low salt, low fat TN diet, and 4-point CBG monitoring done pre-breakfast and 2 hours post-meals. At 28 weeks and 3 days age of gestation, patient experienced vaginal spotting, not associated with watery vaginal discharge and hypogastric pain, and noted with good fetal movement. Patient sought consult at the Geneva OPD with internal examination of cervix 3 centimeters dilated, 50% effaced, intact bag of water, cephalic, floating. Patient was then advised to transfer to the ER, and at the ER, CBG monitoring was not on hand, but her usual pre-breakfast range was 80 to 90 milligrams per deciliter, with 2 hours post-meals that never increases to 100 milligrams deciliter. So at the ER, patient was advised for admission. However, during that time, it was afternoon po, and the RT-PCR swab test is not available. So due to the possibility of the progression of labor, patient was advised to transfer to other hospital because there are also no available COVID rooms during this time. So the patient went to 4 different hospitals, but only one government hospital did an assessment on her with an internal examination. According, patient verbalized that her doctor said that her internal examination during that time is cervix 1 to 2 centimeters dilated, beginning effacement, floating. RT-PCR swab test was also done at this hospital, and the patient decided to just come back to our hospital once with the result. So at 28 weeks and 5 days age of gestation, patient had no recurrence of vaginal spotting. Patient went directly to the ER with a negative RT-PCR swab result, and patient was admitted. So for the physical examination, patient was awake, conscious, and coherent with blood pressure of 120/80, pulse rate of 86 beats per minute, RR of 20 cycles per minute, and a febrile at 36.5 degrees Celsius. Patient is oriented to time, place, and person. Leupold maneuver assessment was breech and slightly oblique in fetal life. HENP, chest and lungs, heart, and extremities were all unremarkable. On the examination of the abdomen, pundic height is 27 centimeters, fetal heart bones of 1/30, which is normal. Patient had uterine contractions occurring every 10 minutes, mild to moderate in intensity, lasting for 50 to 60 seconds. And cervix was pink, smooth with minimal whitish non-foul smelling discharge, and internal examination revealed cervix in mood position, soft, 3 centimeters dilated, 50% effaced, intact bag of water, no presenting part, floating. So for the salient features of this patient, she's a 24-year-old G1P0 who came in with the chief complaint of vaginal spotting, not associated with watery vaginal discharge and hypogastric pain, noted with good fetal movement. LMP was September 25, 2020 with an AOG of 28 and 5 days. Patient was diagnosed during prenatal checkup with bacterial vaginosis and gestational diabetes mellitus, with noted uterine contractions of every 10 minutes, mild to moderate in intensity, lasting for 50 to 60 seconds. On Leupold's maneuver, assessment was breech on oblique fetal lie. The internal examination is cervix 3 centimeters dilated, 50% effaced, intact bag of water, no presenting part floating. So for the admitting diagnosis, G1P0, pregnancy uterine, 28 and 5 weeks, age of gestation by last menstrual period, which in preterm labor, gestational diabetes mellitus. On admission, plan was for tocolysis and completion of steroids. So at the labor room on the first hospital day, patient was noted with vaginal spotting with the same IE. And patient was administered with betamethasone 12 milligrams intramuscularly every 24 hours for 2 doses and magnesium sulfate with a loading dose of 4 grams, low IV push for 20 minutes and maintenance dose of 10 grams at 1 liter plain LR to run for 1 grams per hour. During the second and third hospital day, it was unremarkable. However, on the fourth hospital day, still no recurrence of vaginal spotting, but the patient noted to have hypogastric pain. During this time, magnesium sulfate is already completed for 13 hours and betamethasone is completed for 16 hours. A patient was noted to have uterine contractions of every 3 minutes, moderate in intensity, lasting for 50 to 60 seconds, and with a fetal heart rate of 160. Internal examination during this time was 5 centimeters dilated, almost fully effaced, intact bag of water, no presenting part floating. Assessment is G1P0 pregnancy uterine 29 and 1/7 weeks age of gestation, breech in preterm labor, gestational diabetes mellitus. Due to the progression of labor, plan was for emergency primary low transfer cesarean section for malpresentation.
What's the weight of your baby?
Doc, I wasn't able to get the estimated fetal weight po because I wasn't able to get the ultrasound po of the patient po.
Okay. Why am I asking the weight of the baby? Why is it important in the management of this patient, this particular patient?
We can check for intrauterine growth restriction if the patient will be viable if we perform cesarean section po. So if, of course, we do not want to have cesarean section na masasayang po. So we have to determine if the patient is really viable po.
Is it just for viability?
For possible spontaneous delivery po to.
Okay. To rephrase the question, is there room for vaginal delivery?
For this patient po, spontaneous vaginal delivery is not considered po because this is the first pregnancy of the patient and it is in breech presentation po. So the pelvic diameter was not measured and during this time po, the head circumference is greater than the chest or the abdominal circumference po. So it is dangerous for the baby if we attempt spontaneous vaginal delivery because we can risk for head entrapment po and easy breakage of the bones of the baby po.
But it's 28 weeks already. Your baby would not be, I think, would surmise would not be anything less than 2 kilos or 1.5 even or 1. You're at 28 weeks. Usually, the weight of the baby would be around 800 to 1.2 grams, 1.2 kilograms. That's why I'm asking if you knew the weight of the baby beforehand. That's why a cesarean section was performed, even if it's not malpresented. Why for preterm delivery, what have you encountered any recommendation for cesarean section or for route of delivery according to weight?
What I know po, Doc, usually they are delivered via spontaneous vaginal delivery po.
Ba't ito na CS? Kung sasabihin mong usually, the standard of care would be spontaneous vaginal delivery. You do not augment, meaning you don't put oxytocin because it's preterm. You await for spontaneous vaginal delivery for the baby to deliver. But why in this case was a cesarean section performed? And most likely, even if I do not know the result of that latest ultrasound, I would surmise that this would be the reason. We do not perform cesarean section on what? What's the cut-off weight? Didn't encounter any readings. Any fetus that would be less than 1.5, not advisable to undergo spontaneous vaginal delivery. Although that's a case-to-case basis. Pag lalabas naman na, wala nang magagawa. But they say that it because the baby would not have would have less chance of surviving the physical trauma of labor in the birth canal, we opt for cesarean section in this kind of patients. Okay? Although your malpresentation may be a factor as well, your head circumference, but at 28 weeks, not much. Maybe earlier, it would be. Okay? Go ahead.
So, the procedure was emergency primary low transfer cesarean section with preoperative IE of cervix 5 centimeters dilated, fully effaced, intact bag of water, no presenting part floating. Upon opening, amniotic fluid was thinly stained, baby was in transverse lie, head on the maternal left, delivered the baby on cephalic presentation with no cord coil, and placenta was located anteriorly. So, the outcome of this baby is life.
Ayan na lumabas. 1,000 grams lang.
Yes.
So, hindi lang siya breech malpresentation.
Yes po.
Transverse lie siya.
Yes po.
Okay. For example, this was kinda bigger. Or what's the transverse lie that you could do a cesarean that you could still do a vaginal delivery on? So remember, you have your transverse lie back up or your transverse lie back down. What back up or back down could you still do a vaginal delivery on?
Back down po.
Back down? Are you sure?
For cesarean po ba to?
For vaginal. If you want to go vaginal, you have to check that it is transverse back up. Why back up? Because you have your limbs to grab so that you could position the baby to a cephalic presentation more or less. If it is back down, when you put your hands in, it would be the fetal back that you would get and you won't have any limbs to grab onto to manipulate the baby. Okay? So if it's transverse lie back down, then you have to do a cesarean section. Okay, next slide.
So the outcome of the baby is a live preterm baby boy with a birth weight of 1021 grams, very low birth weight, birth length of 38 centimeters, APGAR score of 2.4457, Balliard score of 28 weeks, appropriate for gestational age.
Okay, so ang liit ni baby, kaya siya na CS.
Yes po. So, After the procedure, patient had an unremarkable stay at the PACU, and she was then transferred to the Junelta ward. Day 1 post-op, patient had no subjective complaints with noted flatus and voiding freely. Plan for during this time was for the removal of indwelling Foley catheter. Patient started on clear diet and was given cefuroxime 500 milligrams per tab every 12 hours to complete for 7 days. On day 2 post-op, still with no subjective complaints, patient noted with flatus, voiding freely, and already have bowel movements. Vital signs are BP of 110/80, pulse rate of 95, RR of 18, and temperature of 36.6 degrees Celsius. Patient was shifted to soft diet and may go home. So for the final diagnosis, it is G1P10101, pregnancy uterine, delivered live, preterm, rich baby boy, 28 weeks appropriate for gestational age, birth weight of 1021 grams, upward score of 2, 4, 4, 5, and 7, via primary low transfer cesarean section for malpresentation, gestational diabetes mellitus. So for the discussion, definition of terms, threatened preterm labor is defined as documented uterine contractions but without evidence of cervical change, while preterm labor is defined as increased uterine activity and cervical change that will ultimately lead to expulsion of uterine contents at more than 20 weeks age of gestation and less than 37 weeks age of gestation. Preterm birth is defined as birth before 37 completed weeks, with early preterm defined as before 33 and 6 days weeks age of gestation, while late preterm is between 34 and 36 completed weeks. So there are 4 major causes of preterm birth. One is uterine distension due to multifetal pregnancy and hypamnios, maternal fetal stress that may be due to nutrient restriction, obesity, infection, and diabetes, cervical dysfunction, premature cervical remodeling precedes premature labor onset, and infection, wherein ascending infection is considered to be the most common entry route. So among these 4 major causes of preterm birth, what we can consider to be the cause of the preterm birth of the patient is the maternal fetal stress and the infection because of the history of bacterial vaginosis and gestational diabetes mellitus. So for the maternal fetal stress, pathophysiology of maternal fetal stress induced preterm birth. One potential mechanism for stress-induced preterm birth is premature activation of the placental, adrenal, endocrine axis. Activation of this axis yields rising maternal serum levels of placental-derived corticotrophin-releasing hormone, which works with the ACTH. This raises adult and fetal adrenal steroid hormone production and promotes early loss of uterine quiescence. If preterm delivery is associated with an early activation of the fetal adrenal placental endocrine axis, maternal estrogen levels would likely be prematurely elevated. And physiologically, this premature rise in estrogen levels may alter myometrial quiescence and accelerate cervical rise. The possible cause of the maternal fetal stress for this patient is diabetes. So diabetes in pregnancy can be classified either overt diabetes or gestational diabetes mellitus. So for overt diabetes, this is also known as pre-gestational diabetes, where in pregnancy in pre-existing diabetes. So the patient already had a past medical history of diabetes prior to pregnancy. It may either be type 1 or type 2 diabetes mellitus. While for gestational diabetes mellitus, according to ACOG, it is defined as carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. So our patient is diagnosed as gestational diabetes mellitus. So during normal pregnancy, we expect that the patient to have normal glucose metabolism. As you increase your blood sugar, your pancreas will secrete insulin enough to combat the hyperglycemia, especially during the first few hours after eating. And several hormones secreted by the placenta, such as estrogen, progesterone, HCG, and placental lactogen, has a diabetogenic effects. Hence, all pregnant women have a tendency to become diabetic. But during second trimester, the number of the number of hormones produced by the placenta is progressively increasing, causing the patient to be diabetic. This will eventually lead to insulin resistance. So this table is from William, shows risk-based recommended screening strategy for detecting GDM. So the assessment of GDM risk should be done at the first prenatal visit. Patient with low risk for developing GDM is not routinely required to test for blood glucose if all of the following are present: member of an ethnic group with a low prevalence of GDM, no known diabetes in first-degree relatives, age of less than 25 years old, weight normal before pregnancy, weight normal at birth, and no history of abnormal glucose metabolism. For average risk patients, blood glucose testing is done at 24 to 28 weeks using either two-step procedure with 50 grams OGCT followed by a diagnostic 100 grams OGTT, or one-step procedure of diagnostic 100 grams OGTT. While for high-risk patients such as those with severe obesity, strong family history of type 2 diabetes, and previous history of GDM, impaired glucose metabolism, or glucosuria, blood glucose testing is done as soon as feasible. If on the first screening of patients with high risk, if the blood glucose is normal, it should be repeated at 24 to 28 weeks age of gestation, or at any time symptoms or signs suggest hyperglycemia. This diagram shows the simplified GDM screening po. So, pregnant women not known to have pre-existing diabetes and or risk factors should be screened for GDM at 24 to 28 weeks age of gestation. So, for our patient, we don't have sufficient data that will tell us that the patient has a high risk for developing GDM. So, there are no risk factors from the history. Thereby, the OGTT was performed on her 24th week age of gestation, wherein the 75 grams OGTT revealed an elevated blood glucose of 181.87 milligrams per deciliter. But for pregnant women who are obese with a family history of diabetes and past medical history of diabetes, GDM screening is done at the first prenatal checkup. If the level shows more than 92 to 126 milligrams per deciliter, GDM is diagnosed, but if it is below, test for GDM is done at 24 to 28 weeks age of gestation with 2R75 grams OGTT. This table shows the different values that are used for reference on diagnosing the diabetes in pregnancy. So for our patient, she had an elevated blood glucose of more than 180 milligrams per deciliter, and according to Pulse, this is already elevated for 75 grams OGTT on 1 hour postprandial po. And for the management of diabetes, women with gestational diabetes can be divided into two functional classes using fasting glucose levels. For non-pharmacologic, it is the DM diet and exercise. DM diet nutritional instructions generally include a carbohydrate-controlled diet sufficient to maintain normal glycemia and avoid ketosis. And ACOG suggests that carbohydrate intake be limited to 40% of total calories. The remaining calories are appointed to give 20% as protein and 40% as fat. For exercise, ACOG recommends regular physical activity that incorporates aerobic and strength conditioning exercise during pregnancy and extends this to women with gestational diabetes. Exercise during pregnancy in women with gestational diabetes also lowers the glucose levels. And pharmacological methods are usually recommended if diet modification does not consistently maintain the fasting plasma glucose levels of less than 95 milligrams per deciliter or the 2-hour postprandial glucose of less than 120 milligrams per deciliter. So for the pharmacologic treatment, it can be with insulin or oral hypoglycemic agents. For insulin treatment, it has been considered the first-line agent and the standard therapy in women with gestational diabetes when target glucose levels cannot be consistently achieved through nutrition and exercise. It does not cross the placenta, and tight glycemic control can typically achieve. Insulin therapy is typically added if fasting levels persistently exceed nga po of 95 milligrams per deciliter in women with gestational diabetes. And ACOG also recommends that insulin be considered in women with 1 hour postprandial levels that persistently exceed 140 milligrams per deciliter or those with 2-hour levels of more than 120 milligrams per deciliter. While for oral hypoglycemic agents, this consists of metformin and glyburide. So, like metformin, glyburide crosses the placenta and reaches concentrations in the fetus that are more than 2/3 of maternal levels. And the FDA has not approved use of glyburide and metformin for the treatment of gestational diabetes. However, ACOG recognizes both as reasonable choices for second-line glycemic control in women with gestational diabetes. For glucose monitoring, women using daily blood glucose of self-monitoring had significantly fewer macrosomic reports, and ACOG and the American Diabetes Association recommend glucose assessment 4 times daily. The first check is performed fasting, and the remainder are done 1 or 2 hours after each meal. So for our patient, she had the 4-point CBG monitoring, and the levels that the target levels that we should achieve for this patient to continue non-pharmacologic management is a fasting blood glucose concentration of less than 95, 1 hour postprandial of less than 140, and 2-hour postprandial of less than 120. So for the postpartum evaluation of patients with diabetes, recommendations for postpartum evaluation are based on the 50% likelihood of women with gestational diabetes developing overt diabetes within 20 years. ACOG recommends either a fasting glucose or 75 grams 2-hour OGTT at 4 to 12 weeks postpartum for the diagnosis of overt diabetes, and the American Diabetes Association recommends testing at least every 3 years in women with a history of gestational diabetes but normal postpartum glucose screening. Women with a history of gestational diabetes are also at risk for cardiovascular complications associated with dyslipidemia, hypertension, and abdominal obesity, which is also known as the metabolic syndrome. Second major causes that we can attribute for the preterm birth of this patient is the infection. Bacteria can gain access to intrauterine tissues through transplacental transfer of maternal systemic infection, retrograde flow of infection into the peritoneal cavity via the fallopian tubes, ascending infection with bacteria from the vagina and the cervix. And I would just like to take note that intraamniotic infection is the primary cause of preterm labor in pregnancies with intact membranes and accounts for 25 to 40% of preterm births. For the pathophysiology of infection-induced preterm labor, exposure to bacterial endotoxins causes activation of residual cells and leukocytes, causing the release of endotoxin, cytokines, and chemokines. And as I have discussed earlier, the premature activation of the fetal HPA cascade will stimulate the release of placental CRH and cortisol as well as DHEAS. The cortisol will stimulate the secretion of prostaglandins, while the DHEAS stimulate the estrogen, stimulate the release of estrogen, and this will cause the cervical ripening and myometrial activation, leading to preterm labor. While during infection, inflammation causes protease synthesis, and these proteases weaken the amnion and the chorion, causing the preterm premature rupture of membrane and subsequently preterm labor. So there are several contributory factors to preterm birth. One is pregnancy factors such as threatened abortion and light and heavy bleeding. For our patient, she had light bleeding or history of light bleeding or vaginal spotting. Lifestyle factors include cigarette smoking, inadequate maternal weight gain, and illicit drug use. Extremes of maternal weight, which is both underweight and obese mothers. Young or advanced maternal age, poverty, short stature, vitamin C deficiency, and psychological factors. Genetic factors, recurrent familial and racial nature of preterm birth, suggest that genetics may play a causal role, and immunoregulatory genes in potentiates chorioamnionitis. Periodontal disease is significantly associated with preterm birth. Interval between pregnancy of less than 18 months and more than 59 months, and prior preterm birth as the most important risk factor, with recurrent preterm delivery risk for women with a preterm first delivery was threefold greater. And another one that is present in our patient is the history of infection with bacterial vaginosis. So bacterial vaginosis is a condition wherein normal hydrogen peroxide producing lactobacillus predominant vaginal flora is replaced with anaerobes. Bacterial vaginosis has been associated with spontaneous abortion, preterm labor, preterm premature rupture of membranes, chorioamnionitis, and amniotic fluid infection. Environmental factors appear to be important in bacterial vaginosis development. Exposure to chronic stress, ethnic differences, and frequent or recent blushing are associated with higher rates of the condition. And bacterial vaginosis is determined and graded by the Nugent score or assessed clinically with AMSEL criteria. This slide shows the summary of the etiologic agent, diagnostic feature, and treatment of bacterial vaginosis. So etiologic agents for bacterial vaginosis include Gardnerella vaginalis, Mobilungus species, and Mycoplasma hominis. Diagnostic features include vaginal pH of more than 4.5, homogeneous vaginal discharge that may be whitish to grayish in color, amine odor when vaginal secretions are mixed with KOH with a characteristic of fishy odor, vaginal epithelial cells heavily coated with bacilli, also known as glue cells, and gram staining of vaginal secretions show few white cells along with mixed flora. So treatment for bacterial vaginosis is metronidazole 500 milligrams per tab twice a day for 7 days, which is given to our patient. So for the diagnosis of preterm labor, first is the symptoms of painful or painless contractions, pelvic pressure, menstrual-like cramps, watery vaginal discharge, and lower back pain. What was present in our patient is the painless contraction and the menstrual-like cramps or the hypogastric pain experienced by the patient. Cervical change, asymptomatic cervical dilatation after mid-pregnancy. Next is ambulatory uterine monitoring, wherein an external topodynamometer is belted around the abdomen and connected to an electronic waist recorder. However, ACOG does not recommend this expensive, bulky, and time-consuming system, which does not reduce the rate of preterm birth. And lastly is the fetal fibronectin. Detection in cervical vaginal secretions of fetal fibronectin before membrane rupture was a possible marker for impending preterm labor, and values exceeding 50 ng per ml are considered positive. This slide shows the traditional criteria in diagnosing preterm labor. So there should be a presence of persistent uterine contractions accompanied by dilatation or effacement of the cervix or both, which are reasonably accurate. Frequency should be greater than or equal to 6 contractions per hour. So for our patient, she had on her first visit, on the assessment at the ER, she had total of 6 contractions occurring every 10 minutes. Cervical dilatation was also at 3 centimeters, and also criteria include effacement of greater than or equal to 80% and membrane rupture or occurrence of bleeding, which are not present on the first assessment on our patient. So how do we prevent preterm birth? One is the cervical cerclage. Prevention of preterm birth remains an elusive goal. Of options, surgical placement may be used to prevent preterm birth in at least 3 circumstances. First, the procedure may benefit women who have a history of recurrent mid-trimester losses and who are diagnosed with cervical insufficiency. A second instance is the woman identified during sonographic examination with short cervix, and the third indication is a rescue cerclage done emergently when cervical incompetence is recognized in women with threatened preterm labor. And short cervix, which is defined as length of less than 25 millimeters diagnosed sonographically, short cervix alone does not prove to be beneficial on this procedure, while very short cervix of less than 15 millimeters with history of prior preterm birth is thought would likely to benefit in cervical cerclage. Next is the prophylaxis with progestogen compounds. During human parturition, maternal, fetal, and amniotic fluid progesterone levels remain elevated. It has been proposed that human parturition involves functional progesterone withdrawal mediated by decreased activity of progesterone receptors that may block the preterm labor. Both the ACOG and the Society for Maternal Fetal Medicine approved the use of progestogen therapy for prevention of preterm birth in select women with singleton pregnancies. Criteria are a history of prior preterm birth or no prior preterm birth with a sonographically identified short cervix. Management of preterm labor with intact membranes. For our patient, what was given is the corticosteroids and the magnesium sulfate. Corticosteroid therapy was effective in lowering the incidence of RDS and neonatal mortality rates if birth was delayed for at least 24 hours after the initiation. Treatment was associated with lower rates of perinatal death, neonatal death, RDH, intraventricular hemorrhage, necrotizing enterocolitis, and need for mechanical ventilation, and systemic infection in the first 48 hours of life. A single course of corticosteroids is currently recommended by the ACOG for women between 24 and 34 weeks who are at risk for delivery within 7 days. So, corticosteroid can be administered by using betamethasone 12 milligrams every 24 hours for 2 doses or dexamethasone 6 milligrams every 12 hours for 4 doses. While for magnesium sulfate, very low birth weight neonates whose mothers were treated with magnesium sulfate for preterm labor or preeclampsia were found to have reduced incidence of cerebral palsy at 3 years. This prevents also cerebral palsy in neonates, and it is given at 24 to 31 weeks to women at risk of imminent preterm delivery. Dosage will be 6 grams loading dose, followed by infusion of 2 grams per hour for at least 12 hours. And other management for preterm labor with intact membranes is in the Williams include amniocentesis to detect infection, antimicrobial, bed rest, cervical pessaries, and emergency or rescue cerclage. However, these procedures are either not recommended or still controversial if it is effective or not to prevent the preterm labor. Next is the tocolysis to preterm labor. So ACOG has concluded that tocolytic agents do not markedly prolong gestation but may delay delivery in some women for up to 48 hours. This may allow transport to an obstetrical center with higher level neonatal care and permit time for a course of corticosteroid therapy. So this includes the beta-adrenergic receptor agonists such as vitrodin, terbutaline, and isoxazoline, which reduces intracellular calcium and decrease contractile proteins, therefore preventing preterm birth po. So parental beta agonists prevent preterm birth for at least 48 hours for maternal transport and giving steroids. And side effects include pulmonary edema, volume overload, arrhythmia, and myocardial ischemia. Next is magnesium sulfate, which is given to our patients. Ionic magnesium in sufficiently high concentration can alter myometrial contractility. Its role is presumably that of calcium antagonist, and when given in pharmacologic doses, it may inhibit labor. Intravenous magnesium sulfate is given as 4 grams IV loading dose followed by a continuous infusion of 2 grams per hour. This usually arrests labor. However, However, magnesium sulfate can cause also pulmonary edema, and FDA has warned against prolonged use of magnesium sulfate given to arrest preterm labor because of bone thinning and fractures in fetuses exposed for more than 5 to 7 days. Next are the prostaglandin inhibitors such as indomethacin. This inhibits the prostaglandin synthesis. Therefore, as I have discussed earlier, prostaglandin has an effect on inducing cervical ripening and myometrial contraction. Side effects include patent ductus arteriosus, oligohydramnios, necrotizing enterocolitis, and intraventricular hemorrhage. Other tocolytics include nitric oxide donors such as nitroglycerin, which has not proven to be effective and causes maternal hypotension, atosiban, which is a competitive antagonist of oxytocin-induced contractions. This is the only drug formulated for preterm labor, also considered as true tocolytic. While lastly is the calcium channel blockers such as nifedipine. Myometrial activity is directly related to the cytoplasmic free calcium and reduced calcium concentrations that inhibit contractions. Calcium channel blockers, especially nifedipine, are safer and more effective tocolytic agents than beta agonist drugs. But I would like to emphasize that the combination of nifedipine with magnesium for tocolysis is potentially dangerous. Studies show that nifedipine enhances the neuromuscular blocking effects of magnesium, which can interfere with pulmonary and cardiac function. That's all po. Thank you.
Okay, very comprehensive report. Very good. In this matter, it was not controlled, but you have mentioned the armamentarium of management. I'm sorry. For preterm labor. Okay. For diagnostics, what do you request for in the ultrasound, particularly to tell if there is preterm labor or not, and what are the parameters? Have you encountered? Have extensively discussed the clinical. If you are to back it up or confirm your diagnosis of preterm labor, what will you request for?
We can request for the ultrasound nga po to check for the presentation, the estimated fetal weight of the patient, and as well as the amniotic fluid index po of the patient.
What else? Have you encountered cervical length and funneling?
No po, Doc. I just read po that cervical length can be assessed sonographically po from Williams po.
What could be done would be cervical length and funneling. We measure cervical length. What's the average length of a normal cervix?
35 millimeters.
Okay, it's 3.5. We measure the cervical length. If it's any less than 2.5, then that is a ground for admission to control preterm labor. If not, you could manage outpatient. Funneling is when cervix is closed, but the inside cervix is open. So you could imagine that it is V-shaped, U-shaped depending on effacement. So that would also be a parameter for preterm labor. Okay, but that is Nice to know at your level. Okay. How will you advise this patient with regards to her next pregnancy?
First po, with yun nga po, postpartum evaluation of the blood glucose levels in order to prevent over-diabetes and also control her diet, her weight po, because obesity is a high risk for developing diabetes po. And, ayun po.
With regards to preterm labor, what is the risk for her to have another preterm labor?
Prior preterm birth po.
Do you know the percentage?
Sorry, Doc, I forgot.
If I remember right, one prior preterm birth increases the risk by 9%. Okay? Another preterm birth, so 2 previous preterm deliveries would increase the patient to as much as 41% to 50%. So that's why eliciting the history of preterm birth is very important so that you could anticipate problems that may arise in the current pregnancy. Okay? Any questions? Very good presentations. Nag-exam na ba? Nakailang exam na yung shifting out batch?
One pa lang po, Doc, nung first month po.
One pa lang. Kailan nyo gusto mag-exam? Bukas? Wala naman pala kayong choice, no? April 30 na bukas.
Yes po,
Want
Doc.
it in the morning? Pwede naman
Okay
ako
lang.
sa gabi. Gusto nyo alas 11 ng gabi, walang problema.
Doc, may scheduled lang po yung iba, RT-PCR for tomorrow po.
Ay, gawin na natin 6 o'clock or kahit 7? Anong oras yung RT-PCR schedule?
Morning po yata,
Morning
Doc.
po, Doc. 10 to 11 po bukas, Doc. 10 a.m. to 11 a.m.
Hindi ako pwede sa hapon eh. Okay lang ba? Sa bagay ibibigay ko lang naman sa inyo yun. Bahala na kayo sa buhay nyo. Sige. Anong oras nyo gusto? What time do you want? Pag-usapan nyo pa ba?
Doc, for both batches na po ba yan? Or yung OT2 lang?
Both batches. Magbobotohan pa ba kayo kung anong oras kayo mag-exam? Anong
Doc,
oras
kung
nyo
kailan
gusto?
na lang po kayo pwede. After na lang po siguro ng Williams Club, Doc.
Anong Williams Club nyo?
May 1 p.m. po kami, pero ano pa po, subject for...
O sige,
changes
text nyo na lang ako pag subject to change after Williams Club. Kahit
Okay po.
late na kayo matapos. Alright, unahin nyo muna yon. Okay.
Okay po, Doc. Thank you po.
Thank you, Doc.
Thank you.